Well, my name's Sean Coffey. I'm one of the research fellows, again, working in the Oxford Biomedical Research Centre. I'm going to be dealing with a disease that presents often very similar to diabetes in that it's picked up completely incidentally without people realizing that they've had it, often for a very long time. I'm going to take a slightly different tack. As cardiologists, we love looking at pictures. And so for most of the talk, I'm just going to take you through what is heart valve disease, because I think a lot of people aren't quite au fait with it. And then just towards the end, I'll just describe one of the projects that we're doing here in Oxford. Now, so to know about heart valve disease, you have to know about hearts. Okay, so we'll go take you through all of hearts in the next minute. So this is a heart. The little red lines on the outside are the coronary arteries that supply blood to the heart. And that's all we're going to say about those for today. So the blood comes in from your veins, the blue blood there, into the right side of the heart, and it gets pumped out to the lungs to pick up oxygen. As it comes into the right side of the heart, it goes through the tricuspid valve first, into the pumping chamber, the ventricle, and goes out through the pulmonary valve. Goes off to the lungs, picks up the oxygen there, and comes into the left-hand side of the heart. It goes into the left side, and then that's the main pumping chamber, and it'll pump that blood out to the rest of the body. So it delivers the oxygenated blood out to the rest of the body. And as it comes in through there, through the left side of the heart, goes to the mitral valve and then the aortic valve. So there's 4 valves in the heart, and their job is to make sure the blood's going the right direction. So it's like a door. You want the door to open freely and let things through, and equally when it closes, you don't want things to go back through it. So that's cardiology. You've learned cardiology. Great. So we'll go through the heart valves now in a bit more detail. So this is just a still picture of the heart. This is a cardiac MRI, and you might be thinking that is a gorgeous heart, and you'd be right, because it's my heart from a few months ago. And so this is me in the MRI scanner. And when we look at the valves, so here is this is the tricuspid valve here, and we just to kind of confuse people, we flip it around so it's back to front, so right and left as if you're the person rather than as if you're looking at the person. And the mitral valve on the left-hand side. Now, because the left-hand side has to do most of the work delivering the oxygenated blood around the body, those are the valves that come under the most pressure. And so when we talk about heart valve disease, most of the time we're talking about valve disease on the left-hand side of the heart. So that's the mitral valve, just here. And the other one is the aortic valve. And so the aortic valve is the valve that joins the pumping chamber, the main pumping chamber, the left ventricle, to the aorta, the main big blood vessel in the heart. And when you look at what causes trouble, what valve disease causes trouble, the aortic valve causes by far and away the most mortality of any valve disease, all right? And so it's the major one that leads to problems. You can see it here. This is MRI as well, and it's 3 leaflets, and when it's working, it just opens fully. It opens freely without any kind of restriction to the flow at all. So that's what it's like when it's working the way it should. So what's heart valve disease? Well, you know, valves they've only got that one job, which is to keep the blood flowing in the correct direction. And so the only 2 things that can go wrong with it really are that if it doesn't let the blood through, or if instead it lets the blood leak backwards, okay? So it stops the blood going forward, or lets blood that's meant to be going forward go backwards. And so that's narrowing or leaking. And just to confuse the public, instead of calling it narrowing, we call it stenosis. Instead of calling it leaking, we call it regurgitation. But that's all it is. It's really nothing more special than that. So aortic stenosis, this is the most important valve disease. And the reason for that is that it causes the most deaths, and it's the valve disease that leads to most requirement for us to do something, to intervene. So a normal valve here is 3 leaflets, and it opens freely. So what happens with aortic stenosis? Well, with aortic stenosis, you get a buildup of material along the base, okay? And so when I see people in clinic, I say it's kind of like a rusty hinge, and it affects the opening of the valve as it progresses. And when you actually look, and this valve isn't particularly narrow, when you look at really diseased valves, if you take them out at surgery, they're absolutely rigid, and it's a very hard chalk-like material. In around a quarter of cases, you can see frank bone inside in the valve. And so it becomes very rigid and stiff. And what that leads to then, just like if a door is rusty, you need to give it a bit of an extra push to open it. And so the heart is required to generate additional pressure to open up that valve. And as the disease progresses, and it does progress, it gets harder and harder to open it until you get to a point where the heart says, you know, I've had enough. I'm just going to take it easy here, and it starts to fail. So that's what it looks like on a picture. So what do we see? And so the way we look at this is transthoracic echo, and that's just a fancy way of saying ultrasound, all right? And so after the talk here, we've got an ultrasound machine set up just down the corridor here. It's the exact ultrasound that we use out in GP practices. And we've got a volunteer who also happens to be one of our data administrators. And when I say volunteer, probably strong-armed is a better description. But if you want to go and see that, the room isn't big enough for everyone, but we can probably fit 10 or 12 people in at a time. If you just sign up at the desk out here, just after the talk here, you'll be able to come along and see it. And so so that's what we do. We put the probe just on the chest here, on the front of the chest, and around the side are the 2 main views, and we get this sort of a picture where this is the aortic valve here, and that should be opening completely freely. This is it from the side here, and you can see instead of opening out like this, it's kind of stuck down, and it's very bright and thick, and that's because the bone-like material, the calcium, or chalk in there reflects the ultrasound back, and so you get this really bright-looking valve. And you can see in this heart, there's still a very good pumping motion of the heart there, but as the disease progresses and the pressure builds up, then that starts to fail. So that's aortic stenosis. So the next one then, mitral regurgitation, that's probably the next most common. And this is if you're in the top of the heart and you're looking down into the heart. And you can see it's a very different structure to the last valve. So there's 2 leaflets, one big one here, the anterior, and then the posterior. And these little things here, these are cords that hold those leaflets into place. And with each beat, as the heart pumps, that shuts, and those cords hold it in position, all right? So this is it just in cross-section, and you can see here there's a big overlap there of the valve leaflets, and so most of the problems with the mitral valve come because that mechanism doesn't work anymore. And that might be because one leaflet slips back on the other, and that's prolapse. So this is prolapse here, where you have one leaflet here, the posterior leaflet is slipping back on the other, leaving a little hole there, letting the blood go right through. And that with the mitral valve is a lot trickier than the aortic valve in a lot of ways, because The other thing that can happen is you can just stretch those leaflets apart. The valve could be actually a perfect leaflet, but it's not coming together. Or one of the cords underneath there could fray or it could snap, and then you run into problems. And so this is an example here of someone whose cord has snapped. And you can see here, instead of coming together like this, like it should, this leaflet here is going right back behind it. And there's this big gap here between the two leaflets. And you can just about make out here a little linear kind of thing flicking around. And that's one of the cords that's broken off and flicked back in there. What's this now? This is how we look at how the blood flows in the heart. This is called color Doppler. And it gives every bit of blood going through the heart is given a color depending on whether it's going up or down. All right, so it's fairly straightforward. It's meant to be kind of these sort of colors, but here you can see it's all a big mess of color, and that's because the blood is all leaking backwards back into the top of the heart. And so that's what we see. If any of you have had heart valve disease, you'll often find at this point we want a little bit more information. And so instead of doing a scan from the outside, the next step is to do a scan from the inside. So we get you to swallow down a scanner, which sounds actually worse than it is. It's actually not that bad a procedure. But then the scanner is right next to the back of the heart, and you get much better quality pictures. And you can see here, instead of this kind of bit of a mess of color, this is the same patient, you can see exactly that the leaking is going up around the top of the, around the back of that normal looking heart valve. And so you can get all this extra information by doing these additional images. So those are the two main types of heart valve disease. So if you're a patient with heart valve disease, what do you notice? Well, when it gets really bad, the main problem is that your body isn't getting the blood to the muscles, to the head, and to the heart that it needs, all right? And so you find you're just not able to do the things you normally would be able to do. And so you get out of breath. You might get angina because your heart isn't getting enough blood. If it's really bad and you try and do something, you might not get enough blood to your head, and that's when you black out. And these things then are a signal that the heart is kind of running out of juice a little bit. And so you're a step away from heart failure. And so what's heart failure? Well, one type of heart failure, so this is a normal heart here on the left-hand side, and you can see it kind of has like a little bullet shape to the ventricle. And that's one of the best ways of providing kind of mechanical efficiency with every squeeze. If you put a lot of extra blood in there, or if there's too much pressure on the heart, after a while it'll get bigger, it becomes saggy, and you lose a lot of that mechanical efficiency. And so each pump often won't be as efficient. And once that's started to happen, from our point of view, things are going to get very difficult, okay? Because dealing with the valve and any treatments that you might want, first of all, are far, far more hazardous, but also they're much less likely to be effective. So you can pass a point of no return with these heart valve diseases. So that's the heart pumping. Other problems you can get with the heart valve is that the heart muscle can thicken up, or it can dilate out like you saw in the last picture. And that can lead to problems like heart rhythm problems, where you get a very rapid electrical conduction around the heart, and that can lead to sudden death. More commonly, you can get an irregular heart rhythm called atrial fibrillation, or AF, and I'm sure you know people who have that. And in this sort of situation, although the rhythm itself probably won't kill you, it does raise your risk of stroke very considerably. And so people end up having to have their blood thinned on things like warfarin or some of the newer blood thinners. Other problems is that you can have aortic aneurysm. And what's an aortic aneurysm? Well, The aorta is that big blood vessel that comes around the top of the heart. And this is a normal aorta, normal size aorta. This is a normal valve. And you can see the blood flow through the valve and out the aorta is perfectly smooth, it's perfectly linear. And that actually doesn't create a huge amount of stress on the wall of the aorta. What happens if you have an abnormal valve? So the most common one we think of is a bicuspid valve. That's where instead of having 3 leaflets, you have 2. You get very abnormal motion of the blood through the aorta. And so you get this helical motion. And so instead of it going out smoothly, you get this twisting effect. And that puts far more stress on the wall of the aorta. And it gets bigger. And then in the worst case scenario, the whole thing can burst or rupture. And that's very hard to survive. And so there's a number of knock-on effects from heart valve disease. And really what you would like to do is to pick this up early and do something about it before you get to the point where you've got a big aneurysm or before you get to the point where you've got a heart rhythm problem or something like that. How do we treat heart valve disease? Well, there's no medical therapy for any form of heart valve disease. It's not that people haven't tried. People have tried a few things. None of them have shown any benefit whatsoever. And so really you're left with open heart surgery as the first protocol. And so as people get older, open heart surgery and going on to a heart-lung bypass machine becomes a much bigger undertaking and becomes a lot harder to recover from. And what we found is that a lot of people would be at that point where they're not able to tolerate surgery like that. And so that led to the development of these transcatheter valves. So that's where you have a valve inside in a tube, and you put it in via a blood vessel and put it into position and expand it out. So this sort of a thing where you have the blue as the catheter, and inside in that is the new valve kind of squashed down. You put it into position, blow up a balloon, and it squashes the old valve against the wall of the artery, and the new valve then works away. Now that sounds really good in theory, okay, and it is good in practice too, but it's not as good as you think, all right? It's still a big procedure. Oops. This one here, if I can get it to play. This is a real procedure, and you can see it's not quite as pretty as what's going on here. For one thing, you got this big tube down here, so the person is under anesthetic. They've got a tube down. This is the transesophageal echo that you just saw. You've got this lead here, which is a pacing wire going up to make the heart. You have to make the heart stop to get it into position. So you've got that wire there. And you've got really what is a very big tube that's got to go into arteries that are often not much bigger than the tube itself. And so the procedure itself, while it offers a lot of option to people who otherwise couldn't have any treatment, and has been shown really quite definitively to improve symptoms and improve mortality and things like that, it's not the be-all and end-all, and we still have a long way to go with treatment of these conditions. So then that leads on to things like, what are we going to do about it? And the first thing we need to do is try and work out how many people have it and why do they have it. And so this is a study mainly from the US, and you can see most people with heart valve disease are older people. And this study was done started in the late 80s. It was done on this sort of machine, and when you see the machine we've got, you'll realize how antiquated that looks. It recorded the pictures onto VHS tape, and if you look at the pictures themselves, it's like looking through a snowstorm compared to what we see now, all right? And so these sort of studies, while they're good, probably aren't as accurate as what we could do now. The other thing is that in those days, in the 80s, over 75 was a really old age. These days, if I see someone age 75 in clinic, I know I'm dealing with a youngster and I can pretty much throw the kitchen sink at them. It's people who are 85, 90 are actually the people that are hard to work out what to do with. So that led on to the OxValve study, if I can get this to go on. No. So this has just died. Anyway, so that led on to the OxValve study. And so what we wanted was information. What's it like in the UK? We wanted to focus on older age groups because that's actually where the difficulties in decision making are, but it's also where most valve disease is. And so what we've set up is the OxValve study based in general practices. Anyone over the age of 65 who hasn't previously been diagnosed with valve disease is invited. And at the moment, we've got open sites in Donington, Temple Cowley, and Bicester Health Centre was just opened last week. And we've finished recruiting in Didcot and Broadshires, and in, help me out, Banbury, that's right. So we're trying to recruit around about 5,000. We've got 3,500 people in here. And so that's the OxValve study as it stands now. The more important things are trying to work out who's going to get it and why do they get it. And I'm afraid I can't tell you that. That's going to be, if you come back here in 5 years' time, I hopefully will have those kind of answers for you. But at the moment, that's where we stand. And so as part of the OxValve study, we certainly welcome the public's opinion. Everyone who comes to us, at the end of it, we ask them to write any comments that they have, and we have changed the study as a result of that. We haven't had to change it too much recently on the basis of that after we ironed out maybe some initial teething problems. But I think that's the nature of it, is that when you get this kind of feedback, you find out what people appreciate and what they don't appreciate. Overall, most people like to take part, and they like the idea that we can provide instant feedback at the time of coming to the GP surgery. And for most of them, it's just a single one-off visit. The people who were recruited right at the start have started ringing us up, asking when we're going to go back and scan them again. And hopefully we'll be doing that in the next 12 months or so. So look, I'll leave it there. I'd like to give a lot of acknowledgements to people, but realistically, a big project like this requires a huge amount of teamwork, and to get 3,500 people scanned in GP practice is not an easy feat. And so it has been a big project, but I think it's been a very worthwhile one as well. So thank you for your attention and for coming on.